Hi guys, this is Jason Williams, DO. This is the Williams Family Medicine channel, helping you to live your best life. Today I wanted to talk about cholesterol. Before I get into the discussion, I want to give you a disclaimer or two. First off, cholesterol treatment and importance is a bit controversial, and this video probably will raise questions and maybe additional controversy. Second of all, if I am not your doctor, I would like you to talk to your own doctor about your medical care. If you are my patient, you can use this video for supplemental information and we can discuss further in the office. I'm a family medicine physician. I am not a lipidologist. I have reviewed several articles regarding cholesterol and longevity. Some of the articles are well done, some are not. I've listened to tons of podcasts about opinions. I have also watched YouTube videos, and I've read books addressing cholesterol. I want you to know that this video is a compilation of my thoughts from observation, reviewing the studies and the data that's out there. So first of all, just to briefly talk about cholesterol, this will be a very simplified explanation and not in enough detail for some. Cholesterol is needed for all of your cells of your body. It's important for immune function, cell structure, hormone production, such as the sex hormones, and even vitamin D. Today, we will discuss one of the critical functions of cholesterol, which will be energy transport. Once again, this is very simplified, but cholesterol can be broken down into types of cholesterol based on particle size. We have VLDL, LDL, and HDL. There are many other particle sizes, but just to simplify for discussion today, VLDL stands for very low density lipoprotein, LDL stands for low density lipoprotein, and HDL stands for high density lipoprotein. Mechanistically, just to simplify this discussion, the liver produces VLDL particles and they get released into the bloodstream. These particles carry triglycerides and cholesterol. The function of VLDL is to bring cholesterol and triglycerides to muscles and tissue. After the VLDL brings this energy to the muscle and tissue, it dumps its cargo and transforms into what is called an LDL, a low density lipoprotein. The low density lipoprotein now is floating in the bloodstream. Sometimes it returns to the liver, or sometimes it also interacts with HDL cholesterol in the bloodstream. HDL cholesterol, high density lipoprotein, is felt to be the good cholesterol. The HDL benefits seem to involve removal of plaque in vessel walls and prevention of oxidation. Oxidation is the formation of free radicals. Think of it as rust forming on a nail, a similar process. We call that oxidation. This occurs in your body and can be damaging to your tissues. In the face of a high carbohydrate or high sugar intake, the HDL cholesterol becomes damaged. It now cannot perform its functions as well as it should, such as removing plaque from vessel walls and preventing oxidation. A consequence of this is the triglyceride content increases and LDL particle sizes become smaller. Hence we call them small dense LDL. Because these particles are smaller, the body recognizes that and decides to crank out more LDL particles. Now there are more particles in the bloodstream and more opportunity for them to become damaged or oxidized, like we discussed earlier, rusted. These small dense LDL particles are thought to be more atherogenic or more likely to produce a plaque in a blood vessel. They certainly have identified increased inflammation with small LDL particle size. If we think about atherosclerosis, the theory is that atherosclerosis is an inflammatory process. Your innate immune system recognizes inflammation and tries to attack it. Immune system cells infiltrate blood vessel walls and cause the wall to swell, kind of early plaque formation. As a result, the blood vessel is narrowed and now also loses elasticity due to effects on collagen, the connective tissue in the vessel wall. This can result in decreased blood flow to organs such as the heart. Other minerals seem to attach to this area of plaque and become calcified at times, probably an attempt for your body to repair itself. If this plaque ruptures, this causes a significant cascade of events that often results in heart attack or stroke. This is why we care about atherosclerosis. This might be a leap, but I guess the question is, why do we care about cholesterol altogether? If you look at treatment guidelines and you are a patient between 40 and 75 years old, and you have at least a 10% 10-year risk of a cardiovascular event, then it is recommended that you are on statin therapy to decrease that risk. Statin therapy has been found to decrease LDL cholesterol. Inherent in those guidelines for lowering LDL cholesterol is recommendation for lifestyle modification. This step may be overlooked by many. It's very easy for a physician to write a prescription for a statin and not even discuss lifestyle modification. It is also very easy for patients to not want to adopt lifestyle modification, as that is hard. It's a big change for them sometimes. If you look at cardiovascular risk studies and consider triglycerides, HDL, LDL, you can identify that the triglyceride to HDL ratio is a pretty good marker for risk of cardiovascular events. That ratio being low, life is better. If that ratio is high, then increased risk for events. How do we apply this information to patients? This becomes the tricky part. I've tried to examine the evidence to make a decision, and I'm still formulating that currently. When I think about medications, I think about the SGLT2 inhibitor class of medications. These medications are designed for diabetics. They came out to help improve blood sugar control. It was identified that they also decrease cardiovascular risk at the same time. The odd thing is these medications happen to increase LDL cholesterol. These medications function by causing ketosis, basically causing you to pee out sugar in your urine, decreasing your sugar content in the bloodstream. And then your body becomes more reliant on ketones for fuel. Another point that I found interesting is that the American Diabetic Association used to have LDL cholesterol as a risk factor for vascular disease, but that has quietly dropped off the guidelines. I listened to an interview from a cardiologist by the name of Dr. Ali, and he referred to his experience with cardiothoracic surgeons in his practice. Cardiothoracic surgeons have an opportunity to know a patient's blood work results, as well as visually see the inside of a blood vessel when they're doing surgery. Unfortunately, for us, cardiovascular surgeons are unable to tell us what the LDL cholesterol will be based on how the vessel looks. Sometimes the LDL cholesterol is high with significant atherosclerosis, and sometimes the LDL cholesterol is low with significant atherosclerosis. The same cardiologist mentioned a condition called A-beta lipoproteinemia. In reviewing this condition, this is a genetic disorder that causes you to have decreased cholesterol, triglyceride, and LDL production. Unfortunately, people that are cursed with this condition have a very short lifespan, often die in their 50s. Along the way, their quality of life is terrible. They have blindness, anemia, GI bleeds, liver cirrhosis, and severe recurrent infections. They also suffer from significant neuropathy and are often unable to walk. Overall, terrible quality of life, even though LDL cholesterol is very low. Some individuals that have been identified to have high cholesterol readings have taken it upon themselves to try to investigate further. There's a fascinating story of a software engineer, not even a healthcare worker, by the name of Dave Feldman. He was identified to have elevated cholesterol and triglyceride readings. He used a lot of resources to specifically capture exact food and drink that he ate with dated and time-stamped pictures, and then serial blood draws looking at his lipids, sometimes blood draws on multiple subsequent days. He was interested in this because he was on a low-carb, high-fat diet and noticed his cholesterol and triglycerides markedly increased. He was also able to prove that he could swing his cholesterol and triglycerides by significant numbers just with changing diet, adding in carbohydrates or decreasing carbohydrates in his diet, sometimes in the magnitude of hundreds of points within days. This makes me wonder exactly what is the importance of cholesterol readings in overall vascular health. Support for statin therapy because of decreased inflammation. Measurements such as C-reactive protein level and other markers of inflammation have been touted as decreased by cholesterol medication. I'm not sure if this is true, but it's an interesting fact, and I still want to learn more about this. We need to be careful when looking at studies The Jupiter trial, which is a famous primary prevention cardiovascular trial with statins, is one example. In this study, they identified patients that seemed to have a normal LDL cholesterol and an elevated C-reactive protein, so an elevated marker for inflammation, and they were able to demonstrate a 37% reduction in inflammatory marker levels. They also claimed decreased cardiovascular events. They reported a relative risk reduction of 44%. The reason I say be careful with this study is it seems like they're using statistical trickery, and actually the absolute risk reduction is more like 0.5% with the use of statin therapy. Statins seemed to come out in the 1990s, and that was a time when the FDA did not regulate medications quite as tightly as today. And so this medication may have slipped through without as much oversight as some today. There are many side effects of statin therapy, and for a medication that you may take 20, 30, 40, or even 50 years, one must consider, is this really safe to take this long? Some of the side effects include liver inflammation, muscle pain, erectile dysfunction, memory deficits, increased risk of diabetes, even up to 10% increased risk, and decreased energy level due to inhibition of coenzyme Q10. If you take all cholesterol studies out there and pool them together and do a meta-analysis, if you truly assess what's happening, you will find that people that have a higher cholesterol reading actually have longer lifespan and improved quality of life. If you are concerned about taking a statin for cardiovascular risk reduction, then we can discuss further. One of the tests that some people lean on is a coronary calcium score, basically a low-dose CT scan of your coronary arteries. You get a calcium score and you can compare that to expected for your age group and then risk stratify. You can also perform this test in serial fashion over multiple years to see about progression. This is an evolving diagnostic technique, but may be useful for some people to assess their cardiovascular risk. It may also help some people to decide whether or not they want to take a statin medication. I have a lot of patients on statin therapy. I always have a discussion with them about the medication and side effects and possible benefits. Some stay on the medication and some decide to discontinue it. I'm still learning as I go and will certainly use any new information as part of my recommendations and treatment for my patients. Once again, this is a controversial video, and I don't want to come off as a cholesterol hater. I just want to come off more as a knowledge seeker. I hope this information can be helpful for my patients to give them perspective in how I'm thinking. If you're my patient, then you may use this as supplemental information. If you are not my patient, then you need to discuss your medical care with your own physician. This is Jason Williams, DO. This is the Williams Family Medicine Channel, helping you to live your best life.